Hi everyone, I'm Pranoti Hiremath. I'm a second-year cardiology fellow at Johns Hopkins. This is a talk about COVID-19 and cardiovascular disease that I was asked to give to our interventional cardiology group, and we are sharing it with everyone. As you might imagine, this is a dynamic area with data that is constantly being changed and revised. Not much is known, and we should be cautious not to anchor heavily on the little data that we do have. But it is always helpful to know a little bit more about what's coming, and I've attempted to distill that from trustworthy sources, relying heavily on the American College of Cardiology webinar from March 18th that interfaced with the CCA and authors of the early Chinese publications. My goals are to briefly cover current data geared toward cardiologists, considerations for cardiologists and the cath lab in COVID-19 patients, and our cardiology fellow efforts at Johns Hopkins. This is the epidemiology of the outbreak from the Johns Hopkins website. Thus far, cases continue to rise. In the last 2 days, many institutions are beginning to see more COVID cases in the U.S. ACC webinar yesterday emphasized the downtrend of COVID-19 cases in China. Yesterday was the first day without a new case in China. Notably, the Chinese are still under strict distancing precautions, and these have not relaxed yet. Unfortunately, Europe has 82,000 cases and 3,400 dead as of today, which is higher than China. These are the initial epidemiologic data from China published in JAMA in February, describing features of the disease. Notably, they had over 44,000 confirmed cases, of which 900 or so were asymptomatic. 87% of their patients were aged 30 to 79 years, but 8% were younger than 30 years, and they did have 1,000 or so cases under the age of 20 years. 14% of patients were severe and 5% were critical. Case fatality was 2.3% overall, 15% in those above 80 years, and 8% in those above 70 years. The mortality rates in Italy are reported to be higher. The US CDC just released data today that 40% of hospitalized patients are ages 20 to 54, and half of the 121 patients admitted to intensive care units in the US were adults under 65. The infection rate for healthcare personnel was 3.8% of all cases coming out of this initial study from China, but was 63% in Wuhan. 15% of healthcare personnel cases were classified as severe or critical. COVID patients with cardiac comorbidities, a study of 70,000 cases demonstrated fatality of 10.5%. In a study of 138 patients, ARDS was seen in 20%, arrhythmia seen in 17%, and acute cardiac injury in 7%. Data compiled nicely in the ACC clinical bulletin states that the same value of 10.5% fatality for cardiovascular comorbidities, 6% for both hypertension and chronic respiratory disease, 7% for diabetes. The R-naught is the number of people to whom one person will spread the disease. The R-naught calculated out of Wuhan was between 2 and 3, suggesting exponential growth. In comparison, the Diamond Princess R-naught was 15, and the goal is to get it to less than 1 in order for the pandemic to end. The initial incubation period of the virus was found to be 5 for most days, and the 95th percentile incubation was 12.5 days. The virus transfers person to person by a large droplet transmission. Airborne precautions remained controversial and were initially advised because the virus was stable in aerosols. Current guidelines disagree. Canada and the World Health Organization recommend droplet precautions for routine care, but airborne precautions for aerosol-generating procedures, including intubation, non-invasive ventilation, and CPR. The CDC previously recommended airborne precautions all the time, but subsequently reverted to droplet due to concern that N95s will run out. Fomites are obviously a mode of transmission. This was just released in New England Journal of Medicine. In aerosols, the half-life of the live virus is 1.2 hours. The virus was found alive on plastic and steel even after 72 hours, but shorter times for copper and cardboard. Mode of transmission brings us to isolation protocols. Fever clinic was implemented early on in China, and entire hospitals were built for suspected COVID patients. Remote consultation seemed to be the key approach, especially for cardiologists. In cardiology, there was remote consultation if inpatient admission was required. Patients who needed a cath were transferred to a designated hospital with a designated cath lab. In-person consent was obtained only from family members without any history of close contact with the patient. Switching gears here to describe the pathophysiology of COVID and mechanisms of cardiac injury. The virus is SARS-CoV-2. It binds to ACE2 receptors in order to enter cells and replicate. ACE2 is expressed in alveolar epithelial cells. ACE2 is an inverse regulator of RAS, and through the pathway involving ACE2, angiotensin II is degraded into angiotensin 1 through 7, which causes the effects we typically associate with the RAS system. Interestingly, animal experiments in SARS virus found that the level of angiotensin II was significantly increased and ACE2 was downregulated. So ARB was actually utilized to reduce pulmonary edema in these animal studies. Very little is known about the mechanisms besides what we can infer from animal data. Mechanisms of cardiac injury in COVID are not known. Could be ACE2-mediated, hypoxia-induced myocardial injury, microvascular damage, or systemic inflammatory response. Cardiac biopsy was performed in China and showed inflammation and endothelial shedding, but did not show inclusions of the virus. Some of the antiviral medications, such as loperamide, ritonavir, and interferon, are postulated to cause cardiac injury and QTc prolongation. Some of the antiviral medications, such as loperamide, ritonavir, and interferon, are postulated to cause cardiac injury and QTc prolongation. This may be a hidden mechanism of injury, as many patients were receiving loperamide and ritonavir. CardioNerds came out with a great episode regarding ACE2 with Oscar Singolani, and he beautifully describes the ACE and ARB data, including studies I just mentioned. These are some of the clinical features of COVID from adult inpatients who were discharged or died by the end of January. And this is from 2 hospitals in Wuhan. That was 191 inpatients for these 2 hospitals. Interestingly, acute cardiac injury here is 12%, and they also describe hypersensitive troponin I over 28 as their cutoff. Diarrhea here is low in prevalence, but we know from later accounts that diarrhea is thought to be a higher incidence of presentation. Duration of dyspnea was 13 days in survivors. Lymphocyte count followed improvement, as did viral shedding. Inflammatory markers were high, and peripheral T lymphocytes were very low. Interestingly, this particular physician, Dr. Zhu, advocated use of anticoagulation due to abnormal coagulation. It is unclear whether he was using D-dimer alone as a marker of coagulopathy rather than a marker of general illness as we do, or if there were some other features of coagulation and coagulopathy that he was using. These are features of COVID on CT scan. 80% bilateral lung involvement, 65% had ground glass opacities without septal thickening, and 50% had peripheral distribution. This is an example of the rapid progression. Mortality in severe cases with cardiac injury was unsurprisingly very high. A key was to monitor clinical warning indices, including declining lymphocytes and inflammatory cytokines. This was one of the case studies that was presented, an example of what they are terming fulminant myocarditis. A 37-year-old man with chest pain and dyspnea for 3 days, X-ray showed enlarged cardiac silhouette, EKG showed inferior ST elevation, troponin T was over 10,000, and EF was 27%. He was treated with steroids, IVIG, and managed for cardiogenic shock, and 1 week later his EF recovered to 66%. It is unclear whether he tested negative for other etiologies of myocarditis. I'm sure you wouldn't be thrilled about getting called for this STEMI. A 60-year-old man who had inferior STEMI with abnormal LV segmental ball motion was treated with balloon pump, antivirals, and antiplatelets. He was not revascularized initially, and unsurprisingly, 3 weeks later he still had chest pain and ischemia. These are the principles used in China for acute MI therapy. They did want everyone to seek care at the closest medical institution. They did ask all ACS patients with fever to go to a special fever clinic first, where they underwent screening and often PCR testing. They utilized thrombolysis in a time-sensitive way as primary STEMI management for those with confirmed or suspected COVID, and they did transfer acute MI patients with COVID to a single designated hospital. Obviously, there are many components of treatment for critically ill patients, including respiratory and circulatory support, renal replacement therapy, and immunotherapy. Remdesivir is undergoing trials in China, and Gilead has approved this for compassionate use in select patients. The main toxicity and therefore exclusion criteria is liver injury. Other therapies include alpha interferon, ribavirin, chloroquine, favipiravir, and tocilizumab for cytokine release syndrome. Corticosteroids are really controversial, as they have been thought to worsen some cases, but help in others, such as the myocarditis case earlier. ACE and ARB are less of a dilemma at this point, with consensus statements and data suggesting we should continue use. Dr. Singalani also pointed out in his talk this point, which is that 48% of non-survivors had hypertension, whereas 23% of survivors had hypertension. Therefore, the RAS system may not be beneficial in COVID-infected patients, and it must be suppressed. Yesterday, the first randomized clinical trial was released, and the summary is that lopinavir-ritonavir did not have a significant improvement over placebo for time to clinical improvement or mortality. There are obviously many limitations to this study, including the fact that this data was collected on very sick patients in the midst of a growing pandemic. Here is a summary of treatment options. Avoid NSAIDs, avoid systemic and inhaled steroids given potential harm, not start an ACE or ARB, or continue prior ACE inhibitor or ARB. Use a statin for cardioprotection in all patients. For moderate or severe cases, remdesivir is currently undergoing clinical trials and can be obtained for compassionate use. Hydroxychloroquine and chloroquine are thought to inhibit either inflammation from COVID or else ACE2 and the virus directly, and the mechanism is currently unclear. Lopinavir and ritonavir can also be trialed, with caution regarding cardiovascular side effects. In refractory cases, interferon beta-1 should be considered, and in cytokine release syndrome, tocilizumab. To discuss some cardiology-specific consideration, the first question is, what will be our protocols for ACS and myocardial injury? STEMI is one consideration since thrombolysis may be an approach for the most critically ill patients. Newly reduced LVEF is another scenario to consider. We need more information about the incidence of true myocarditis in order to aid our approach. In order to minimize infection, and also if the incidence of myocarditis is truly very high, we may choose detailed echo assessment first, as well as coronary CTA in cases that are more stable from a respiratory and heart rate perspective. Second, should there be a single designated cath lab for SARS-CoV-2 confirmed or suspected cases? This was the Chinese model. Also, how should we screen COVID patients, as our acutely ill patients often cannot provide a good history? Third, what will be our ECMO and mechanical circulatory support approach, and what is our capacity? What are the risks and benefits of a bedside cannulation approach? And of course, the institution of a heart team is more critical than ever. Finally, just a thought for the lab and hospital intensivists. What will be our protocol to code COVID patients? Because CPR and intubation increase risk of aerosol-mediated transmission, everyone would need an N95 and proper PPE during the code. We may need to make some changes to our general approach. I do want to share a few of the cardiology fellow initiatives from Johns Hopkins from my team. We are creating a Hopkins daily 5-minute audio clip to keep everyone updated and to boost morale. We are consolidating educational resources, restructuring outpatient and inpatient services to limit exposure of our residents, fellows, and faculty. We are also working on clinical research to aggregate data from outpatient and especially inpatient COVID and to rapidly provide info to our frontline clinicians. And finally, we're involved in advocacy for providers at many different levels. Thanks so much for listening. You can find me on Twitter if any questions. Huge shout out to the Johns Hopkins Fellows and Residents, as well as many individuals within Hopkins Cardiology, Interventional Cardiology, and Medicine. Thanks so much to CardioNerds, which is amazing. And finally, thanks to all those at the front lines working to fight COVID. We appreciate you.